Well, good afternoon, everyone. I'm Beth Stewart, and on behalf of the Texas Oral Health Coalition, I would like to welcome you all to our monthly webinar. Today's topic is common lesions of the oral cavity from diagnosis to treatment, presented by Dr. Paras Patel. If you should have any questions regarding the evaluation process or need assistance, please don't hesitate to contact us at info@texoc.org. Dr. Paras B. Patel is a board-certified oral and maxillofacial pathologist who obtained his dental degree from Howard University College of Dentistry in 2011. Dr. Patel went on to practice general dentistry for a couple of years in the Lubbock area, working on a mobile dental unit with a federally qualified health center. In 2014, he began his residency in oral and maxillofacial pathology at Texas A&M University College of Dentistry. Upon completion of his residency, Dr. Patel took a position at the College of Dentistry and is currently a full-time faculty member in the Department of Diagnostic Sciences. He maintains a clinical practice actively seeing patients who suffer from various oral diseases in the Stomatology Center at the College of Dentistry, and is an active surgical pathologist in a busy biopsy service. Dr. Patel's previous work experience and curiosity have shaped his approach to diagnosis and management of disease. So it is with extreme pleasure I give you Dr. Patel.
Thank you, Beth. And again, a big thank you to the Texas Oral Health Coalition for allowing me to present this series. It's been a pleasure, and hopefully we're going to go out with a bang. And again, I'm sorry for those of you who were expecting an hour. I am going to drag this on a little bit. It's because I want to show you a lot of fun pictures, and hopefully that correlates to something that you can utilize in your practices. So as Ms. Stewart said, we're going to go through common lesions of the oral cavity. So a lot of this information is going to be really rudimentary in the sense of what lesions we're discussing. But these are the things, they're common for a reason. These are things that you're going to see in your everyday practices. And if you haven't seen some of them before, you will likely see them before you decide to retire or do something else. So there's a chance that you're going to come across these lesions. And again, I'm going to focus on epithelial and soft tissue pathology. We're not going to be looking at any radiographic images. And so it's kind of limited to that extent. And it's still quite a few cases and lesions that I do have to share. So it was just Halloween, so I figured I'm going to start off with something a little casual, but here's my unicorn princess here. He wanted to dress up as a dragon. That's my son. And if you can't tell, I'm this bear of a man that was really hot. It was a lot hotter than I expected it to be on Halloween night. This thing was almost like a sauna suit. So I have a tendency to keep these things pretty casual. If you haven't joined us before, if you do have questions, again, we'll keep an eye on the chat box, and feel free to type them in as we go along. And I'll try to slow down as much as possible, but I do want to make sure we can get through the material in a timely manner. All right. So just a little disclaimer in regards to the images that I'm using. I do have a couple of images that are pulled from text. So they're textbook images for a reason. They really illustrate the pathologic process. A lot of the other cases that I have are cases that I've seen clinically myself, or cases that I've been involved in as a pathologist, and I've gotten from clinicians around the state and around the country, or colleagues from even international locations in a couple of these. So what are we going to cover today? We're going to start off with kind of common bumps and lumps that we'll encounter in the oral cavity, followed by inflammatory lesions, and we'll focus on those that are infectious and more common, as well as those that are non-infectious in origin, and that's something that you're likely to see also in practice. Then we'll touch on white lesions and end with pigmented lesions. So really the question becomes of what are we not going to cover? Okay, it is a lot of material, but we're going to go through it, and hopefully I'll present it in a way that makes it easy to digest and easy to understand. All right. So the first category is reactive bumps and lumps. and other stuff. So I have a few different things in here that don't necessarily produce a lump or exophytic bump type lesion, right? So when we're talking about reactive disease entities, this category is going to consist of those disease processes that are largely non-neoplastic, okay? And so a lot of them are reactive in nature. So what does that mean for us as clinicians in regards to managing these lesions? Well, complete removal and excision is likely going to be curative for a reactive process. But we also have to make sure that you evaluate for any sort of eliciting factor. So try to figure out what was causing this chronic irritation. Is it an abnormal architecture where there's a plaque catch that's causing constant inflammation and irritation? Is it an ill-fitting denture? Is there something else there that could be causing some degree of chronic low-grade trauma that results in this reactive lesion? Because you could excise it, but if you haven't addressed the eliciting factor, the chance of recurrence is going to be high because you haven't, truly assessed the source of that lesion. So the first thing is a fibroma, and everybody probably remembers this from their training at one point in time or another, but this is a reactive fibrous lesion. It has oma on it, so people assume, oh my gosh, this is a tumor. It is a tumor-like process, but it's not neoplastic. It really is a thickening of that connective tissue. It's most often in response to chronic irritation or trauma. Most common location for this is going to be the buccal mucosa along the occlusal plane, because that's where we're going to have chronic irritation or trauma from mastication. And so that's where we're more likely to find these lesions. They're going to be smooth surface nodular in their appearance. They can become traumatized through mastication or if the patient bites on them. So they may present with an ulcerated surface or some white changes along that surface as well. Typically, it's asymptomatic. The patient knows it's there, or the patient may not be fully aware that it's there, but it usually doesn't present with pain or symptoms unless, again, they've traumatized it by chewing on it or biting it. So classic example along the occlusal plane, again, near the commissure. So anytime we see a growth like this, the first thing that goes through my mind is, where is this coming from? And clearly the surface is smooth, so whatever is proliferating is from the underlying tissues. So it's a connective tissue proliferation. And there are a lot of different elements there. There are blood vessels, nerves, in some cases there's salivary glands. In bound down mucosa, there's clearly bone. So anytime we see this sort of smooth appearance on the surface, I know that, hey, this is a submucosal lesion, right? And in this case, this was an area along the occlusal plane and pretty much a classic example of a very symmetrical growth that is going to be soft or doughy on palpation, not fluctuant, but at least doughy and compressible on palpation. Some of these may be a little bit more firm, but the big thing is that they're going to be movable, okay? This doesn't infiltrate into the tissues like we associate with aggressive lesions or malignancies, and so it's going to be movable. And those are kind of signs clinically to us that indicate this is likely a benign or reactive process. Another example here on the lower lip, and again, smooth surface nodular lesion, and it has a little bit of a whitish hue to it. And the patient had a history of chronic irritation and trauma to this area. They said that they had bit it multiple times, and you can kind of see a little bit of evidence of some masticatory trauma here with some white changes, and another fibroma in this case. Here's one on the anterior tip of tongue, another common location that we can find these. And this patient had a habit of constantly kind of catching their tongue between a diastema and their anterior mandibular teeth, and it caused enough irritation that it's caused this fibrous hyperplasia and this bump. A lot of times the way I explain this to a patient is that this represents kind of like a hypertrophic scar. And that kind of correlates a little bit better as opposed to using a lot of the scientific terminology that goes behind it. They can kind of understand that, okay, it's a scar like you get on a skin, it's just really thickened. Another one that shows pretty much the same location as that first one on the commissure of the lip here, but you're starting to see some more white changes on the surface and maybe a little area of ulceration, which is not uncommon because they will traumatize these lesions over time. Here's one has a nice little ulcer on top, and that white change is pretty much the epithelium becoming thick or producing a little more keratin on top because there's been that chronic irritation. Again, the body always tries to protect itself, and so that's a little bit of mechanical resistance from that chronic irritation and the body's attempt to kind of toughen up that skin. This is one where the patient came in and says, I have this tumor, it's been hurting me. It's likely that this had been there for a long period of time. They had just bit into it recently, and they were concerned about something like a carcinoma or an oral cancer. And this was very soft, and you could easily move it around. And this almost came down to a stalk type base. Again, all clinical signs that this is likely a benign or reactive process, and this was biopsied, and it was a fibroma with some overlying ulceration. Anybody want to take a guess on this? We're talking about fibromas, so if the guess is made, it's likely going to be a fibroma, but it's not, okay? And this is one that draws attention to what commonly comes in as a fibroma. On the ventral tongue, whenever you see something with this submucosal proliferation with a smooth surface, especially in young kids, these often represent mucoceles, or are the result of mucus extravasation or spillage into the connective tissue, and then the body walling it off and producing this sort of nice exophytic bump. So on the ventral tongue, remember, if you see something like this, particularly in young children, one of the first thoughts or one of the other things to consider in your differential diagnosis would be a mucocele. And a majority of the time, it's going to be a mucocele as opposed to a fibroma. And I'll talk about mucoceles a little bit later on in the lecture as well. So the treatment, what are we going to do? Well, complete excision. And that can be through conventional methods where you're going to do a conventional blade excision. I've seen cases done with electrocautery around the base or laser ablation around the base, making sure that you've excised that tissue completely. Excuse me. One of the big things to remember with this is I tell the patients this is also going to be curative because it's an exophytic bump and the likelihood of them continuing to traumatize it is very high. And in some cases, patients have noted that, oh, it seems like it's getting bigger, but that's that constant irritation that is constantly stimulating that connective tissue and producing this hyperplastic process. And so sometimes it does look and feel like it is getting bigger, and in fact it may be, but whenever you completely excise that tissue, you've removed this from projecting into the oral cavity and from further trauma. So this is a good example. There's clearly some evidence of trauma on the lower lip here. And so we see that, and we have this nice little submucosal bump and fibroma, right? And this is a really good example that reminds me to always discuss the importance of submitting tissue for histopathologic evaluation. And I'm not just saying that because I'm a pathologist. I'm saying that because our clinical judgment can only take us so far. The other part of this is making sure that this is what we're dealing with in certain patients. And so this was biopsied, and a huge surprise to me because this would have not been in my clinical differential diagnosis, but this is a tumorous proliferation of these epithelial islands that show these cystic structures. And when you look at these islands at a little bit higher power, these are mucus cells in here. And these are more epithelial, or what we call epidermoid cells. So this is actually a malignant salivary gland tumor that we find commonly in the oral cavity. It's called a Mucoepidermoid Carcinoma, and rather innocuous clinical presentation, which I would have thought fibroma, maybe a mucocele, but it looked reactive to me. But you can see just again from the architecture, it was just producing that nice little lump lesion, which correlates to what we were seeing clinically. And palpation, likely that maybe that superficial area would have been movable, but there may be some evidence of more of an indurated mass or some thickened connective tissue or firmness whenever you palpate this lesion. So you're going to feel like there's something deeper within the tissue here. And again, that correlates to the proliferation happening deep down into the connective tissue. So inflammatory fibrous hyperplasia, at its core, this is a fibrous hyperplasia like a fibroma. Inflammatory is an adjective because there are inflammatory cells associated with this that have likely resulted in this fibrous hyperplasia, but again, reactive in nature and as a result of some degree of chronic inflammation and irritation. We call these, when they're associated with ill-fitting dentures, epulus fissuratum, which you guys probably remember, but that's kind of the clinical term of these lesions whenever they fit right against an ill-fitting denture along the flange. On the gingiva, we often find these with areas that have irregular buildup of plaque or calculus, or where there's inadequate restorations or poorly placed restorations where you have a large overhang, which again is going to be a plaque catch and cause inflammation and irritation accumulation leading to this fibrous hyperplasia. The other thing to remember is that individuals who are on certain medications are also at an increased susceptibility to developing fibrous hyperplasias. And oral hygiene really plays an important role in regards to the occurrence of that fibrous hyperplasia. So it's not just the medication. Otherwise, we would have everybody that's on calcium channel blockers having fibrous hyperplasia in their mouth, right? Because there's some degree of irritation and inflammation, regardless of how well controlled your oral hygiene is, right? So there are a couple of factors there. Hygiene plays a big role with it, but also in some recent years, we found out that there's likely some genetic factors that also predispose you to developing these sorts of fibrous hyperplasias. And so here's one on the gingiva here, and it was a nice little exophytic bump, and fibrous hyperplasia was the diagnosis, or inflammatory fibrous hyperplasia was the diagnosis. And the patient had a little bit of recession and poor plaque control, which was likely contributing to this. Here's another one on the anterior maxillary gingiva. Nice submucosal bump right along that gingival margin. And once something like this becomes exophytic, it allows for even more plaque to accumulate and more inflammation to occur. So it just feeds into this process. Very important when we're removing these lesions to make sure that you scale and root plane in that area or in that vicinity. Again, looking for that eliciting factor, trying to figure out, is there an overhang on my restorative margin? Is there, an irregular root surface here that's allowing for plaque accumulation? Is there recession? Is the cementum roughened here? So making sure you're scaling and root planing is going to reduce the chance of recurrence in a lot of these cases that affect the gingival tissues. Here's one that looks fairly innocuous as well, except this really prominent white area here. And again, going back to the importance of submission of tissue, you can kind of see this marginal white change here, which is a little bit of a clue to me that this doesn't seem quite like a reactive process. And there's a recent publication within the last months that talk about leukoplakias, which are precancerous lesions, the clinical classic white lesions that we talked about in my oral cancer lecture, that have this sort of involvement of the marginal gingiva. That's a worrisome sign for a more aggressive sort of disease process. And in this case, this patient had a history of something being removed years ago in this area. They were told it was benign, not to worry about it, so they just went about their business. Over time, they started to have a little bit of tooth mobility associated with number 8 here, which again is a clinically worrisome sign for us. The radiograph showed that it looked like there was some bone loss here in this area. And while there's nothing obvious that looks really like it's coming from the surface, this was biopsied and this was actually thought to be completely excised, this nodular mass here, and it was actually squamous cell carcinoma. And this is one of the worrisome things about gingival carcinomas, is they can be fairly innocuous in regards to their clinical presentation and can kind of mimic on occasion things that may be reactive or not locally aggressive. And part of this is the fact that they can grow down that sulcular aspect against that root surface. And so they could be proliferating down along that root surface without having any obvious, fungating mass like we associate with carcinomas in general. Here's an example of a classic epulous fissuratum, clearly ill-fitting denture that's just been causing chronic trauma to this area, just banging against that ridge and the adjacent soft tissues. And you can see the flange fits right in the middle of this. So excision is going to be curative for that lesion, but in the absence of adjusting that denture, it's going to come back. Okay, so you got to do 2 things here to make sure that we have a reduced chance of recurrence. Another example of this, ill-fitting denture, really cobblestone type of ridge as well. And again, this fits up right with that denture flange and that chronic irritation. So realigning, readjusting those dentures, in some cases making a new prosthesis may be necessary to reduce the chance of recurrence in these cases. And a classic example of a drug-induced gingival hyperplasia. And remember, there's a handful of different drugs that can actually cause it, and emphasizing at-home oral hygiene care and potentially getting these patients in for more short duration, short protocol lesions or short protocol prophylaxis, sorry. So getting them in more frequently for a dental prophylaxis is really important. and it may be necessary to do that in some of these patients. So anticonvulsants, antiepileptics is one of the classic ones, calcium channel blockers, cyclosporin often used for immunosuppression in solid organ transplant patients. Oral contraceptives, erythromycin, can also produce a susceptibility for this gingival hyperplasia. All right, so pyogenic granuloma, exuberant sort of vasoproliferative process. The name is awful. It doesn't produce pus. It's not purulent, and it's not granulomatous inflammation. So despite the name, we've had this for decades, and so it makes no sense to continually change stuff up. So we continue to use it. It really is a vasoproliferative process in response to some local irritation. Certain individuals may be more susceptible to developing these, pregnant females, females that are going through a perimenopausal state, or females that are going through puberty. And it's because it's directly correlated with the levels of these particular hormones that can have a direct angiogenic effect, as well as an effect on the smooth muscle that's within the vasculature. 75% of these are found on the gingiva, and the incidence and severity seems to correlate with oral hygiene. So again, one part of this is also oral hygiene. Is there a stimulating factor there? Because this is a reactive process. Oftentimes it's going to be this vascular appearing lesion that's painless, but it may bleed readily whenever you manipulate it. So red to purple in color. Oftentimes you'll have an ulcerated surface, and it does have a tendency to occur in younger individuals and females more often than males. So this is one in a gentleman here on the lower anterior gingiva. And again, when we excise a lesion like this, we want to make sure we scale and root plane in this area, kind of removing any sort of local irritant that may be causing it. Clearly, we've lost some of the tissue in the interdental papilla here. So there's probably more food impaction, and discussing things like that and restorative possibilities for patients like this are really important. Here's one in a female who was pregnant, and the lesion was a little more worrisome. We also had some involvement of the buccal tissues, but appears very densely vascular, purple, red in color, and it was biopsied, and this was a pyogenic granuloma. She did report that there was some kind of rapid growth during her pregnancy, which was a little bit concerning to the clinician, but not uncommon to find these pop up during those times. Here's one on the anterior dorsal tongue. Again, ulcerated surface. This yellowish represents the fibrin membrane where we've lost the epithelium. This was completely excised, and the patient had a history that he had bit his tongue recently. And instead of going through the normal healing process, you ended up having this vasoproliferative reactive lesion that formed this lump-like, tumor-like process that was a pyogenic granuloma. Some of these can get fairly large, and this is one that you wonder, man, how did she hide this for so long? But this had been there on her dorsal tongue, and it almost came down to a stalk. So these are the beautiful cases where the surgery is minimally invasive. It really was more pedunculated lesion, and you could almost clip it at the base, and it's likely curative with a minimal chance of recurrence in this situation. Here's one on the lower lip. Pyogenic granulomas can happen on the skin as well. So this is kind of happening in the area of the vermilion, where we can see it involving portions of that cutaneous aspect as well. And this one looks similar, a little more raised maybe, but the patient had a history of biting his lip. So you know what? Clinician says, I think this is a pyogenic granuloma. I don't have a strong argument against it. One thing he did mention is that when he palpated it, it felt a little more firm, and it wasn't quite readily movable. Again, our clinical signs that can clue us in to maybe something else that may be going on here. So he said, I think it's a pyogenic granuloma. It just wasn't as readily movable as he would expect. It did feel a little bit more fixed in the tissue. So when he biopsied this, we were looking at the histology. And so this is the surface, which is largely ulcerated, which corresponds to this yellowish fibrin membrane here. And underlying in the connective tissue, there are these islands. And these islands are made up of cohesive cells, which are epithelial in nature, and they're clear. They had a clear cytoplasm. So this is a clear cell carcinoma And we can get these from a few locations. Oftentimes we see these in the salivary glands, but they can also be the result of metastatic disease. And in this case, the histomorphology for us as pathologists made us think of renal cell carcinoma. On occasion, they have this specific pattern and these specific histologic features we look for. So we questioned the clinician. Does the patient have a history of renal cell cancer or kidney cancer? Right. And he said, no, nothing to report. The gentleman's healthy. He sees his physician regularly. The only thing is that he's reported some left flank pain recently. So a little bit of lower back pain on the left side. And so we said, well, given what we're seeing here and specific studies that we had done on the tissue, we think this is metastatic renal cell, and the patient needs to be worked up for their primary disease or evaluation of an underlying primary carcinoma. The patient did get evaluated, and this is the patient's left kidney. This is the right here. And you can see this area that's hypodense, which corresponds to the necrotic tumorous mass. So this was a renal cell carcinoma that was discovered after the surgeon decided to biopsy the actual oral cavity lesion. And this patient unfortunately had pulmonary nodules, which were consistent with metastatic foci of renal cell. They had metastases to the liver, and this is a portion of your pelvic bone, and it had a 5-centimeter metastatic focus in there as well. So this was an unfortunate case of a stage 4 advanced stage renal cell carcinoma. Again, sees his physician regularly, no other major complaints. And this was something that, again, we could be seeing in our practices. Whenever metastases affect the jaw or the oral cavity, the most common location is going to be the jawbone. Whenever they affect the soft tissues, most common location is going to be gingiva. And most frequently, they're going to present as a reactive bump. And more often than not, they're described as pyogenic granulomas. They look vasoproliferative. So something to kind of keep in the back of our mind whenever we're evaluating patients. Clearly, the common lesions are going to be more common, but something that you always have to consider whenever you're actually going about treatment and management for these patients. Peripheral giant cell granuloma, another reactive lesion that is limited to the oral bound down mucosa. It's a result of local irritation, exclusively again on the gingiva and alveolar mucosa. It has this really exuberant reddish bluish hue. And if that's clinically present, that's going to be your kind of thought that I think this might be a peripheral giant cell granuloma. And that's because this lesion has a lot of red cell extravasation. So there's a lot of red blood cells that are extravasated into the stroma that give it sort of that vascular hue to it. It may cause some slight cupping resorption of the underlying bone, and typically excision down to the underlying bone with the thorough scaling and root planing is going to be adequate in regards to a curative procedure. However, some of these do have a tendency to recur, and the recurrence rate is about 10%. So, eliminating local factors are clearly going to reduce the chance of recurrence. Really purplish hue to this, and this was biopsied, and this is a great example of a peripheral giant cell granuloma. Here's another one, almost like a little kidney bean sitting on the buccal aspect here. But you can kind of appreciate this blue, dusky sort of purple color to it. And that again is from that red cell extravasation that we can see histologically. And this is a good example of a peripheral giant cell granuloma. Here's one here that brings up the point of what else do we consider with bumps on the gum? Well, a parulus, right? A draining sinus tract from an infection. And that's why it's always great to correlate with the vitality of the teeth as part of our clinical exam. You see a bump, you don't automatically assume it's X, Y, and Z. You do some other diagnostic tests to rule out other possibilities. Teeth are both vital in this situation. While this almost looks like a little area of purulence, it was actually just a little ulceration. And this was another example of a peripheral giant cell granuloma. And these can happen in edentulous areas as well. Again, the thought is that it may come from periosteum, and that's what produces this. And so this is a large lesion here as a result of chronic denture irritation posteriorly, and that resulted in this peripheral giant cell granuloma. And like I mentioned, these can cause some cupping resorption. And so we're starting to see a little bit of resorption of that posterior alveolar bone there. One of the things that's really important is understanding the need for radiographic correlation with these lesions. These lesions histologically look exactly like what we call a central giant cell granuloma. But oftentimes central giant cell granulomas are intraosseous and they produce a pretty significant radiolucent lesion. And so making sure that this isn't a peripheral manifestation of a central lesion is always important. Central giant cell granulomas can perforate through the cortices and produce a bump on the surface. And so again, correlating with the patient's radiograph, making sure there's not a lytic lesion there is really important when you're evaluating things like this. Peripheral ossifying fibroma. I know we've had a lot of peripheral stuff in here, but this is a common gingival bump, and it's reactive in nature. And again, this one is one that is also limited to the gingiva, like peripheral giant cell granuloma. It's a reactive proliferation caused by local irritation, typically dental plaque or trauma, exclusively on the gingiva in the areas where we have dentition. Okay, so this is one that we won't see in edentulous bands or anything like that. It's believed to originate from the PDL, from the cells from the PDL, and excision down to the underlying bone with scaling and root planing is typically curative, as well as addressing any sort of, poorly restored caries and things like that that may produce a little bit more of a plaque catch. And there is a little bit of a higher recurrence rate with some of these. Here's a classic example. And it looks very similar to the rest of the lesions that I've been showing you, but this yellow represents an area of ulceration, and it's emanating from that interdental or interproximal papilla region, and this is a peripheral ossifying fibroma. Here's one on the palate, a little bit more broad, but it almost had a little bit of a pinched-in base around it, and it was excised, and this was a peripheral ossifying fibroma as well. Here's another one that has caused a little bit of a dehiscence or diastema between the teeth here. And on occasion, and not uncommon, that we'll find these affecting the buccal lingual areas or buccal palatal areas or labial palatal areas. So we can see these kind of emanating from the interproximal papilla, both on the lingual side as well as the buccal side. And as I've mentioned in multiple cases, the importance of making sure that you're evaluating some of this tissue histologically. This is one that kind of looks similar, but the surgeon had a little bit of a concern because it wasn't quite the typical pattern for a reactive lesion. So it did have that kind of buccal palatal sort of involvement, and this was biopsied, and unfortunately that was a squamous cell carcinoma. So some of these lesions can be, again, rather innocuous, but hones back to the importance of submitting some of this tissue for pathologic evaluation. So after learning on all of this stuff that we've taught, or that I've talked to you about now, what are our classic things that we're going to consider in our differential diagnosis for bumps on the gum? Well, as we were taught in dental school, and I teach the hygiene folks here in my residence, you consider the 3 Ps and the F. That's the way I was taught it. Some use 4 Ps, and the 3 Ps are clearly pyogenic granuloma, peripheral giant cell granuloma, and peripheral ossifying fibroma. The 4th P would be a parulus, or the draining sinus tract. And then the last thing, the F, would be a fibrous hyperplasia, whether it's a fibroma or an inflammatory fibrous hyperplasia. And there have been some big studies that have looked at thousands of cases of bumps on the gum, I will say, and a majority of those, close to 90%, if not more than 90%, end up being one of these 4 things. And but it's always, again, important to remember that, hey, there are things that can mimic the bumps on the gum. Metastatic disease is one of them, as well as local primary malignancy. So on occasion, this is one of the things that we do have to consider in the back of our mind. All right, so moving on to mucoceles. A mucocele is the result of trauma or damage to a salivary duct. And now, instead of that duct being connected to the surface and secreting or excreting saliva into the oral cavity, it has been transected somewhere within the soft tissue. And so as a result of that, instead of the saliva being pulled out into the oral cavity, it is now pooling in the connective tissue. And that mucin, your body deems as foreign and establishes an exuberant sort of granulation tissue reaction to it and walls it off and produces a bump. And that is pretty much the basis of a mucocele. This is most commonly seen in children and young adults. Lower lip by far is the most common location, but you have to remember there are other areas where we have salivary gland tissue, the buccal mucosa, the vestibule, the soft palate, floor of mouth. So there's other locations that we can actually see these disease processes occur. Palate is also the most common location, posterior hard palate, soft palate area, for salivary gland tumors. So that's one other thing that whenever we're discussing tumors in that region or bumps in that region, we should also consider a true neoplasm of salivary gland origin. Clinically, it presents as this dome-shaped submucosal lesion that may be kind of bluish in color and fluctuant on palpation, because that is kind of spilled mucin and saliva within that capsule. History may reveal an increase and decrease in size, and that's not uncommon. Okay, some of these, the body has a tendency to form enough granulation tissue, and so as a result of that, you see a decrease in size as you start to see resolution of the lesion. And the important thing is some of these can actually undergo resolution on their own, and the duct will have a tendency to kind of re-epithelialize and connect back to the surface, but some of these are persistent and have to be excised. Classic example, now you guys know that if you see something that looks like a fibroma on the ventral tongue, probably going to be a mucocele, and this was a mucocele on the ventral tongue. Here's one on the lower lip, and you can see it has that bluish hue to it, and it was kind of fluctuant on palpation, and the patient had the classic history that sometimes it's a little bit bigger, sometimes it's smaller, and this was biopsied, and this was a mucocele. So histologically, this is what a mucocele looks like. You have this dense fibrous connective tissue that has granulation tissue along the edge. And if we go down here and you go to this area on a little bit higher power, you'll see that this is the duct from our salivary gland tissue that has been transected. And so now instead of this connecting up to the surface where it would normally, produce saliva into the oral cavity, it is just spilling all the mucin that's being produced and the saliva that's being produced by our glands here into the connective tissue. And all of these cells here are inflammatory cells that are producing this response and then resulting in that dome-shaped lesion that we can appreciate clinically. Another example, sometimes mistaken for a little bit of a blister. Some of these superficial mucoceles that can occur almost look a little bit more translucent, but this is a mucocele in a young patient here. All right, so treatment, again, some may undergo resolution, but if the lesions are persistent, excision is going to be necessary, and it's really important when you excise these lesions at the base, you will see small sort of yellowish little round things at the base of the tissue. And those round things represent salivary glands. And it's really important to pluck out the glands at the base of that lesion, because it's likely one of those glands that's damaged that has resulted in this mucocele. So if you don't remove that duct and you close it back up, the chance is that there may be a recurrence because the duct is still producing mucin out into the connective tissue. So here's a good example of that. This is a nice bump in this individual, and the clinical diagnosis was mucocele by an excellent surgeon here. And if you look at the base, he's relatively cleaned out the base of this lesion, but these are the types of things you're going to see. These yellowish kind of white little nodular protuberances, and most of them are freely movable, and you want to make sure you use your cotton forceps or your other instruments to go ahead and pluck those out to reduce the chance of recurrence of a mucocele. And this is the patient post-operatively, nice suturing technique, minimal scarring with these patients, and they go on about their business with no other issues. They can happen in the floor of the mouth, and oftentimes these are referred to as ranula. And on occasion, they can plunge down below the neck, below the kind of dissect through the mylohyoid muscle and present as a midline neck swelling. So sometimes it depends on where that mucin is actually being produced and where it can go. But we can see these in the oral cavity as well as a plunging ranula is what we call it when it dissects below the mylohyoid muscle. But it has that bluish appearance in this area as well. And this was biopsied as a mucocele. Similar swelling, asymmetrical on this side here. And this was thought to be actually an abscess associated with one of these teeth. The patient had a non-vital tooth here, and they're thinking, okay, we think it may be draining abscess. So they attempted to do an incise and drain, and it was not productive. So they were thinking, okay, it's probably a mucocele. Let's go ahead and sample a piece of it and see what happens. And on the biopsy, this actually showed a Mucoepidermoid Carcinoma. So this was a malignant salivary gland tumor in this patient. Again, looking at this, clearly whatever's happening is below the mucosa. And so there are other things we can consider in our differential diagnosis, but it is mimicking kind of a ranula in this case, or a mucocele in this case. Palpation is one of those things that can be helpful in those cases. Again, thinking about fluctuant versus not, movable versus not, can be helpful in some of those situations when you're considering mucocele or not. All right, hemangioma, benign proliferation of blood vessels. Many people think that this is not a neoplastic process, but more of a hamartoma. And so most commonly observed in infancy, a few different types. It can be capillary or cavernous, or it can have a mixed vessel sort of hemangioma as well. And 60% of these occur in the head and neck region. When they happen in the mouth, the most common location is going to be the tongue, and it's treated through variable methods. Okay, and there's a lot of kind of case-by-case criteria that you have to look at for treatment. The type of hemangioma it is, the age, and other factors. Some young individuals can have really deforming large hemangiomas, and in those cases, propranolol has been used in recent years with quite a great treatment effect and limited side effects as a result of that medication. Prior to that, pulse dye lasers were used often. Intraorally, most of these lesions are excised. They're not high flow lesions, so the chance of you actually having an active bleed are very low. But if you do have concerns, clearly you can get an MRA done if you're thinking that this may be more of a vascular malformation or something along those lines. But excision is typically curative. And in some cases, if it really is in an area where you don't expect it to become traumatized and the patient has had it for a long period of time, some individuals may decide that, hey, we think this is hemangioma, we're just going to keep an eye on it. And they tell the patient of this, and they decide or make that decision sort of together. Here on the tip of the tongue, a small, nice little red nodular lesion representing a proliferation of small capillary type vessels. And this was a capillary hemangioma on biopsy. So again, red nodular lesion there, a little bit more bluish in color. And this is a little bit deeper in the tissue, and you can't really get a full feel of this mass effect. But when you palpate this area, it's a little bit more firm. And this was excised here. And this was a cavernous type of hemangioma, so really large dilated vessels that were deeper in the skeletal muscle as well. So almost of an intramuscular sort of hemangioma in this situation. Clearly a large mass here. You can kind of tell that this is probably something vascular. And this was excised in clinic, no persistent bleeding, no issues with bleeding during the surgery. And this was a large cavernous hemangioma in the posterior tongue. Localized juvenile spongiotic gingival hyperplasia is a mouthful, literally. I guess figuratively, it's not literally a mouthful. It's a lot of words put together, and it's a descriptive name for this specific entity. Dr. John Wright, who was one of my greatest mentors, is one of my greatest mentors here at the College of Dentistry, as I did my residency here. Him, as well as a couple of the other oral pathologists here, along with a former resident, coined this term. And this is an entity that represents this reactive lesion that we see most frequently in children and adolescents. And they're usually found on the anterior facial gingiva, and most often they're localized, hence the name. And it's thought to be a result of exteriorized sulcular epithelium or reactive hyperplasia of a sulcular epithelium. And it's associated with orthodontic treatment or mixed dentition. As the teeth are going through eruption or the teeth are being moved, the thought process is it exteriorizes a portion of that sulcular epithelium, which then interacts with plaque and it becomes proliferative. There is a recurrence rate. Some of these have actually been known to undergo spontaneous resolution. All right. So it's not always plaque associated. That's the big thing with this one. This is the classic example, and it most often comes in with the provisional diagnosis of a pyogenic granuloma. Oftentimes you can really see these little telangiectatic type vessels, these little spots in here. And when you see it on the anterior labial gingiva, it is almost characteristic and diagnostic for this lesional process. So I've been trying to make a push for it to just call it Wright's lesion, and hope he doesn't mind that. But here's another one, and we're starting to see a little bit more mucosal color change here, but kind of red, and you can see those little telangiectatic vessels along the edges, and really characteristic for this sort of process. A little bit clearer, more defined view of those punctate sort of vasculature. And when we look at this histologically, they're really superficial dilated vessels with really thin epithelium at the very top. And so because of that, we get this, exuberant, clinical presentation of this lesional process. Sometimes it can be a little bit more exophytic. Here's a large one here in this patient. And again, it's not always localized. So I've seen a handful of patients at this point through consultation that have multifocal areas of localized juvenile spongiotic gingival hyperplasia or spongiotic gingival hyperplasia. And a lot of times this is brought in and there's concern for leukemia, there's concern for inflammatory disease. More often than not, the patients are asymptomatic. They come in with maybe some poor oral hygiene, but even after correction of the hygiene, these lesions don't resolve. So how do you treat them? Well, you could definitely consider conventional excision, but we're removing so much gingival tissue and probably causing a lot of recession. So there's a few different ways that people have treated these over the years. Laser-based therapy with or without steroid treatment, so a laser ablation of that top layer, followed by a course of topical steroids, has been shown to have some improvement in these lesional processes. And the other thing you have to understand is if some of these do undergo spontaneous resolution, is it necessary to actively treat these lesions, right? So if you can inform the parents that, hey, this is this process, we've biopsied it, this is what we think it is. Some of these may undergo resolution. You make the decision together, okay? The parents are involved or the patient is involved in this decision. Sometimes it's an aesthetic concern, and so they want to get it removed, and that's when you talk about doing different therapies for this. There was a publication in a periodontics journal, the Clinical Advances in Periodontics, about using laser ablation followed by topical steroid therapy, and they had phenomenal results. And you can see here, no recession, or maybe just a little bit, it looks like it was probably already there, very little recession, if any, and great resolution of the lesion after they did ablation as well as topical steroid therapy. All right, benign epithelial proliferations. Now we're going to talk about the papillary stuff. So papilloma, Veruca vulgaris, condyloma acuminatum. You guys should be aware all these things, they have one thing in common. It's HPV, right? And when we talk about HPV, you have to understand it's not necessarily automatically sexually transmitted disease. That's where everybody's mind kind of always goes. It either goes to a sexually transmitted disease or cancer, right? And I'm here to tell you that these lesions are benign lesions. Papilloma and Veruca vulgaris are caused by low-risk HPV, as is condyloma acuminatum. The difference is that papilloma and Veruca vulgaris can be also transmitted through non-sexual contact, okay? Technically, condyloma acuminatum could, but this is the one that we consider a sexually transmitted infection or disease process. Condylomas are the sexually transmitted HPV lesions, often found in the anogenital region. But these lesions can be transmitted, or this infection can be transmitted through non-sexual contact. So you should feel comfortable discussing things like this with your patient. And again, low-risk subtypes, these are not the oncogenic subtypes that result in oropharyngeal cancer. Not oral cancer, oropharyngeal cancer. If you have questions about that, definitely go back to the oral cancer update lecture that we gave earlier a couple of months ago. So HPV is a non-enveloped DNA virus with over 205 different subtypes at this point. For basic purposes, we can stratify them into low and high risk. And a majority of the lesions we're going to talk about are all low risk. So HPV 6 and 11 results in a papilloma. This is probably one of the more common things that we see in our practice and clinically I see on consultation. It can occur in any age, usually a soft, painless exophytic mass with finger-like projections or a pebbly surface, and that's white or mucosal in color, and often pedunculated. So it usually has a little bit of a stalk at its base when it attaches to the underlying connective tissue or mucosa, sorry. Common sites are the tongue, the lips, and the soft palate, with the soft palate being by far the most common location for these to occur. Classic example, looks like a little piece of cauliflower that's just been stuck on there, has this sort of pebbly, roughened surface. And this one looks like it's a little bit more sessile, meaning that it has a broader base attached to the soft palate, very characteristic for a papilloma. Sometimes the projections are a little bit more finger-like or hair-like, and this is one that has the more exophytic sort of projection to it, but very characteristic for a papilloma here. And another one on the soft palate here with the finger-like sort of papillary projections. And you can kind of see it kind of pinches in to the stalk-like base in one area. Really simple excision, minimally invasive, and typically curative. Veruca vulgaris is thought to be caused by a few different subtypes, or the Veruca category is caused by a few different subtypes of HPV, all low risk. Lesions are typically, in the oral lesions are typically the result of autoinoculation. Kids or adults may have these lesions on their fingers or toes. And if you're flexible enough, you can get to your toes. Otherwise, they kind of bite it off of their finger or they chew on it, and that results in inoculation of the lips. And guess where we see these most commonly? In the oral cavity, the vermilion border, the labial mucosa, and the anterior tongue, on occasion the anterior gingiva, the areas where you're exposed to it whenever you bite into it. They typically present as these white painless nodules, not often as pebbly or papillary on their surface. A lot of times they'll be a little bit more flat topped. 2/3 will undergo spontaneous resolution within 2 years. More often than not, these are treated by a dermatologist or another provider, oftentimes with a salicylic acid on the skin to kind of just cauterize, chemically cauterize and burn that lesion away. So here's some in the oral cavity, and these can be excised clinically, and that's typically going to be curative for these patients. But this patient had multiple kind of flat top, but sort of pebbly lesions on the lips. And you look at her fingers and she has these areas where she's clearly bitten away the warts that were there previously. A little bit more pebbly and a little bit more obvious here. And sorry, I'm having a little bit of lag here. Beth, can you guys hear me okay?
Yes, we can hear you just fine.
Okay, all right. I thought I was having a little bit of lag here. But these pebbly lesions on the lower lip, and when we check the patient's fingers, surprise, surprise, this is something that I do regularly. If I feel they have something in the area that looks like a verruca, I ask them about their fingers and toes, or if they have warts on their hands or something like that, because it wouldn't surprise me if we found some of these. So you can see this patient has some warts on his hand, and he's bitten into a couple of them here. And again, more flat topped than the pebbly, or not pebbly, but the papillary lesions I was showing with a papilloma. Classic example of a flat top lesion, really doesn't look papillary, but the way this produces keratin, it produces a thick layer of keratin on top. Histologically, we can appreciate it, and that's why they look a little bit more flat top, but this is a Veruca vulgaris that we received earlier this year. Condyloma acuminatum. Now, this is the one that really is the genital wart, okay, and what we consider to be a sexually transmitted disease. Interestingly, it's also caused more commonly by type 6 and 11, but on occasion, especially those that have been documented in the anogenital region, they can harbor some high-risk subtypes. And very rarely in the anogenital region, we've seen some of these cases undergo malignant transformation. Very different from the papillomas and the Veruca vulgarises that we talk about in the oral cavity. Or on the skin. So again, this is the one that is sexually transmitted, but understanding how to discuss these lesions with your patient is important. I can't tell you how many times we get a papilloma and the provisional diagnosis is condyloma. So I can only imagine how that conversation went with the patient. You know, I usually describe these to my patients as, hey, you know, you got this papillary lesion in your mouth. Kind of reminds me of common warts that people get on their hands, and that makes it a little bit more understandable for the patients themselves. Okay, it allows for you to educate them on what it is and the fact that this can also be non-sexually transmitted. All right, very important to know what terminology you're using. So this is the one that is sexually transmitted. Oftentimes looks more like a mix between a papilloma and a condyloma, more flat-topped, blunted projections. And oftentimes it has a tendency to have multiple lesions together. Most common location, again, the genital region, perianal region, but you can have inoculation to the mouth as well as the larynx. When we see them in the oral cavity, oftentimes it's the site of inoculation or contact. So labial mucosa, on occasion the soft palate, or the lingual frenum is a very common location for us to find condylomas. So here's one, and you can see this little pebbly lesion here, and they have a little one here. And then they have another one on the upper lip. And this patient had a long-standing history of condylomas. They were aware that this is what they were, and that's what the diagnosis was here in this case. This patient also had one on the lingual frenum, a little bit larger, not quite as papillary, but they had those two lesions on the lips, and they had this one on the lingual frenum as well. All right. So treatment for this, again, for papillomas, conventional excision, typically going to be curative. Recurrence is very rare. Veruca on the skin have been used, or topical medications have been used to kind of essentially burn the lesion. And so salicylic acid, lactic acid have been used. Excision, even cryotherapy by dermatology is used on the skin. Intraorally, again, conventional excision is typically going to be curative for those cases. For condylomas, conventional excision in the oral cavity. On occasion, people have used topical medicaments whenever patients have multiple lesions, or laser ablation. There's always a question about laser ablation and the seeding or aerosolization as a result of that ablative process. And conceptually, it makes sense, but with high-speed vacuum and everything that we use in our practices, it is less likely that you are going to infect those around you with ablation. But that is something that you should consider if you have multiple lesions in a patient. Prevention is big. So this vaccination has been out for years now, Gardasil 9, and it protects against 611, 1618, which are the most common oncogenic viruses found in cervical carcinoma in women, as well as oropharyngeal carcinoma in men. So 6 and 11 accounts for a majority of our benign papillary lesions that we see, papillomas and condylomas. And long-term studies are being done, and actually we do have data on this now. And this was published two years ago, I believe, in Lancet. And they saw a substantial decrease in the amount of lesions that they were seeing in patients, both males and females. And then last week, on, I believe, November 3rd, another publication came out of the UK with their HPV vaccination programs. And the conclusion statement was quite impressive. And the data they had was pretty supportive, that they've almost eradicated cervical carcinoma in women who participated in that program starting from 1995, late 1995. So it's very impressive information that's coming out. And this is something that, again, you should feel comfortable talking about with your patients. I had a opportunity to speak last week with a oral surgeon colleague of mine who spoke fairly passionately about this topic. And he said, talk about it as a cancer vaccine and not as an HPV vaccine. And so, again, a lot is to be said about how you portray this information or how you communicate this information to your patients. You automatically say HPV, their mind goes to STD, right? But discussing these things and getting comfortable discussing these things with your patients really is key, because we have an opportunity here to change the demographics of cancer, or this specific type of cancer, cervical as well as oropharyngeal cancer. And not just demographics, but the actual incidence and prevalence. All right, so we're going to inflammatory lesions. Stomatitis is kind of the generic term for inflammation within the mouth. And so we're going to kind of discuss infectious as well as non-infectious disease processes. With infectious, I've limited it to two of the things that you're going to probably see most commonly in your practice, candidiasis and herpes simplex virus infection. And then with non-infectious, some of the more common things that we'll see, and I'll kind of brush through some of those as well. So candidiasis, it's a species that is normally colonizing in 60% of older individuals. individuals, surprisingly close to half of the population, you can find Candida as part of a normal colonizing organism in the oral cavity. Certain factors do increase the chance of an infectious state, and that's host immune status. If a patient is immunosuppressed, it is a fungal organism, and it's going to take that opportunity to overgrow. And so it's an opportunistic infection, right? The oral mucosal environment is another one. Medications, salivary flow, things that alter salivary flow, radiation therapy, things like that. Xerostomia as a result of medications. A lot of different things that can alter the oral mucosa that can result in overgrowth. Clinically, it can have variable appearances. Pseudomembranous candidiasis is the classic white lesion you wipe away and it leaves that red raw surface underneath it. Atrophic candidiasis is often overlooked. And the classic example of that is denture stomatitis, where you have this red change just in the area where a patient has a prosthesis. And then hyperplastic candidiasis, I'm not really going to touch on here. It's kind of one that has a little bit of a contentious debate with it, whether it truly represents candida or not. But oftentimes it produces more of a plaque-like lesion. And there's question as to whether the candidal organism is secondary to a precancerous process, or it is a primary factor that results in this plaque-like lesion that's not wipeable. So pseudomembranous, everybody should be pretty familiar with this. Again, common areas, the palate, buccal mucosa, labial mucosa, the dorsal tongue. But when a patient has generalized pseudomembranous candidiasis, it is fairly easy to recognize. This curd-like thickened white change of the mucosa that with a little bit of pressure, you can wipe those areas off. The patients often complain of soreness or discomfort. Here's, again, the buccal mucosa of the same patient. This is an individual, family friend who had a graft placed from his thigh as a result of a cancer resection. And he had discomfort just limited to the graft area, maybe a little bit of extension here, but you can appreciate that milky yellow-white appearance of these pseudomembranes that were wiped off. And we just easily, prescribed him a suspension of nystatin, which he used for a couple of days. And you can see the graft still looks like a healing or taking graft here, but we've lost that pseudomembranous component to it. Median rhomboid glossitis is a specific type of atrophic candidiasis. There may be some other underlying predisposing factors to the development of this lesion, but typically it presents as this red atrophic area on the midline dorsal tongue. Very rarely, it may produce more of a nodular appearance, and on occasion, the patient may have a kissing lesion or an identical lesion on the portion of the palate. And that's thought to be as you swallow, that portion of your tongue kind of hits up and closes up against the palate. And so you get inoculation and a palatal lesion as well. And then denture stomatitis, again, limited to the areas of denture, very atrophic in its appearance and red. And so the patients have discomfort and just this red change in the mucosa. And then angular cheilitis is another one that we see in individuals have a reduction of their vertical dimension. So once we start to get a little bit of drooping of the tissue here, it creates this nice little moist environment where candidal organisms have a tendency to party and proliferate. And so they like that environment and they have an opportunity to grow there. And it can cause some cracking and some redness. On occasion, it can also be bacterial in nature. And so some of the medications that we use are combined antifungal and antimicrobial more generically. Classic example of atrophic candidiasis in the setting of median rhomboid glossitis. And this is pretty characteristic. You can make this diagnosis clinically. You can treat the patient with antifungals, and in some cases it'll resolve this lesion, but there are likely some other factors here as well, and the lesion may persist, but nothing to be overly concerned about given this presentation. They can appear more nodular, and if you look at this looks like a nice little nodule centrally, but pay attention to the surrounding atrophy. So this is very much atrophic compared to the normal papillary architecture of the tongue here. And this little nodule here is a result of the fact that we have surrounding atrophy as opposed to it truly being a big nodule that's exophytic there. This is our classic example of denture stomatitis. The patient has Poor denture hygiene. They don't take it out at night. Again, it's affecting their anterior maxillary teeth, so they want to keep their teeth in all the time. And they're not cleaning it adequately. So now it's created this environment where candidal organisms have overgrown, and it fits right into the area of their denture. So one of the big things for this, when we manage a patient like this, if you're going to manage it topically, which is what I typically use in my practice, a nystatin suspension, make sure that you're also treating the denture. It's important because if you don't treat the denture, they're going to auto-inoculate every time they put that back in their mouth, okay? And again, it correlates to that partial denture there. Really great example of angular cheilitis. And again, you can use either a mycostatin or nystatin ointment with this, or an antimicrobial cream that is antifungal and antibacterial in nature. So topical therapies, nystatin suspension, 100,000 units per ml is typically what I prescribe. And they use about a teaspoon 4 times a day. And that is typically enough to resolve any sort of candidal infection in most cases. Some cases may be recalcitrant. You can try clotrimazole troches. And these are dissolving little tablets that patients put in their mouth. And the whole idea is that you get a little more substantivity. It's there for a little bit longer, 20 minutes for it to dissolve roughly. So it's going to last a little longer. And then for the angular cheilitis, we can use nystatin ointments or a combination antifungal antibacterial cream, which on occasion will have a steroid in it to help reduce the inflammation and the discomfort and pain that goes along with it. Systemically, patients have been treated with diflucan or fluconazole, and they usually do 100 milligram tablets, 16 tablets, take 2 tablets for the first day and then 1 tablet each day after. Most of these infections are superficial, so I usually stick to a topical method of treatment, but I know colleagues that also treat these systemically as well. Herpes simplex, all right, another one that automatically your mind goes to STD. So it's good to educate the patients about this. 100% of the population in developing countries by the time they're 30 or 50 will be exposed to HSV, particularly HSV1, okay? And in developing or developed countries like us, close to 70 to 80% by the time we're in our 30s and 50s will be exposed to HSV1, okay? And it can be transmitted through sexual and non-sexual contact. The virus infects these epithelial cells, then it travels up the nerve and establishes latency in our neural ganglia. And then it has reactivation later in life with variable stimuli that can produce the disease again later. Interestingly, the virus is shed and can be transmitted in the absence of clinical disease. And 70% of the population actually sheds this virus asymptomatically once a month. No cold sore, no signs of disease, no signs of infection. It is just shed out in your saliva. And that is another way that this could be transmitted to a person who has not been in contact with the virus before, right? So primary infection usually is a 10 to 20 day course. You end up having painful lymphadenopathy, fatigue, fever, and myalgia, which is often followed by a vesicular eruption with crusting on the dry skin. It can affect internal, external genitalia in females, external genitalia in males. Oral cavity clearly can be affected, and it usually subsides within 3 to 5 weeks, okay? When we're talking about the oral cavity specifically, in younger individuals, they typically have a tendency to develop a gingival stomatitis, where you get what looks like acute necrotizing gingivitis. You get these punched out papillas where it looks really ulcerated. Oftentimes, you'll still have the clue that it's herpetic. You'll have those sort of, punctate ulcerations that have a tendency to coalesce or kind of distribute along that pattern in multiple areas, which makes you think, okay, is this something viral, right? Recurrent infection, it can span anywhere from 2 to 6 times a year. Typically in the oral cavity, when we see recurrent herpetic infection in immunocompetent patients, we see it on bound down mucosa. Usually patients do complain of some sort of prodrome. They felt it kind of altered sensation in that area, maybe some tingling or some burning. And then you actually see the development of the lesion, which is vesicular. Then it heals on its own within 10 to 14 days. This was a patient that I was called down to an oral surgery here a couple of years back, and the patient had this crusting of their lip. And if you look at their gingival tissues, my goodness, you have all these punched out papilla here and these necrotic ulcerative looking lesions. And a little bit of a clue, you got these punctate ulcers. So these small little ulcers all in one area. Some of them look like they've kind of coalesced. And again, the sort of ulcerated necrotic looking papilla in multiple areas. That's not why he was there. He said, I needed my third molars out and my teeth hurt. And he clearly has some poor dentition. And when I asked him about his gingival tissues, he said, it hurt a couple of days ago. It's not as bad today. And then I asked him, well, did you have any fever, lymphadenopathy, any fatigue in the last? And he said, yeah, about a week ago, I had a fever. And, I was really tired and I just thought it was some sort of viral thing. And he was right. It was some sort of viral thing. And then he said his gums started to hurt. So that was the preceding factor to the development of his primary herpetic gingivostomatitis. So I said, you're at this point, it's not hurting you that bad. We can try to give you something for pain, but you're not in that much pain. Let's get you back in a week. Just try using some palliative sort of saltwater rinses and let's see how you do. So I got him back next week, and this is literally 7 days later, and that's his oral mucosa. That's his gingival tissue, right? So again, just clinically, this seems like herpetic gingivostomatitis. I have no proof. We didn't do serum studies on this gentleman, but my judgment is that this was likely his primary exposure to HSV. And again, within 1 week, these will resolve on their own. And if there's some persistence, then we need to start considering some other things. Classic example of a recurrent herpetic infection, oftentimes as a result of dental treatment or manipulation from probing, injections, anything like that, crown preps. But this is one that this gentleman has a tendency to get these on the palatal aspect in this area. And again, the punctate sort of ulcerations that have a tendency to coalesce is really characteristic for herpes virus. And so here's another one, and this is kind of the classic cold sore. You have multiple little vesicles that are still intact at this point. And this is a classic example of recurrent herpes labialis. So treatment, if it's primary, if it's treated early enough, so within the first 3 days of the development of symptoms, you can actually shorten the duration and the symptoms in those patients. And there's a handful of medications. In the interest of time, I'm not going to go into detail with these, but there's a lot of anti-herpes viral medications that are available and can be dosed accordingly. Secondary, again, if you have the prodrome symptoms, that's the best time to treat for secondary outbreaks. At the onset of them feeling that abnormality is when you're most likely to get the most effect. Okay, once it's there, once you see the vesicles and ulceration, the virus has done its damage. Okay, now it's in the resolution phase. Really not much is going to make it better. There are some topical ointments, but they usually provide very little benefit. All right, so non-infectious stomatitis. These are some chronic diseases. Geographic tongue. Everybody should be pretty familiar with this, also called benign migratory glossitis or erythema migrans. It's an inflammatory process or condition. We don't know what really causes it. There are some links with specific Hla subtypes and psoriasis. So for some individuals, it may be kind of linked to the fact that they do have psoriasis or this specific type, Hla subtype. Typically, we're going to see it in females, but you can see it in males as well, a 2-to-1 predilection, and it can be seen at any age. Very rarely do we see this in the pediatric population, but on occasion, you could see this in a child, all right? Be careful when you're talking with your patients. If you use the term erythema migrans and you forget mentioning that, hey, this is geographic tongue, they could Google erythema migrans. This is Google. Erythema migrans, the first thing that pops up is this Wikipedia page, and the patient's going to say, oh my gosh, I have Lyme disease. This is horrific. Okay. So again, being careful in the way we communicate things with our patient really is very important. Okay. It's not Lyme disease, right? What does it look like? It's these areas of papillary atrophy and redness with a slightly thickened white to yellow serpiginous border, typically asymptomatic, and it has a pretty distinct correlation to occur with fissured tongue. Oftentimes on the anterior dorsal and lateral tongue is where we'll see this, but it can actually be seen on the soft palate, the ventral tongue, and the floor of the mouth, as well as the buccal and labial mucosa. So this can be seen at other locations, all right? So this is the classic example of geographic tongue, this red area of erythema or atrophy with that serpiginous border going around it. and really prominent fissured tongue in this case as well, with the areas of yellowish change and some papillary atrophy, right? A little bit more innocuous. We don't see that bright red change here, but that serpiginous yellow-white border really gives this away to me that it's geographic tongue. And again, now we have geographic lip, if you want to, humor me on this, but erythema migrans affecting the labial mucosa in this case. And same presentation on the soft palate, same patient, they had it on their labial mucosa and buccal mucosa as well. Sometimes it's a little bit more atypical in its clinical presentation, not really seeing that thick white border, but we do have these areas of atrophy. The clinician at the time thought, I think this is geographic tongue. Let's get you back in a week. Let's see what it looks like. Patient was asymptomatic, so they got the patient back in a couple of weeks, I believe, and it had moved locations. You start to see resolution of one of the lesions, complete resolution, and the posterior lesion looks a little bit different. So not uncommon that patients say that, oh, these lesions kind of move around, they come and go. But this was a good example of a kind of an unusual presentation of geographic tongue. Most patients are going to be asymptomatic, like I said, so just kind of reassuring them of what the process is going to do a lot. If the patient is symptomatic, you may need to treat the patient. Oftentimes a topical steroid will work. Some published cases or studies have shown resolution with zinc supplementation, where they use elemental zinc at 3 to 5 milligrams a day. But in most cases, I've used topical steroids such as Lidex or fluocinolone 0.05%, the gel form, and they apply it 2 to 3 times a day, and making sure that you discuss that anytime we're using a topical steroid in our mouth, we also have the chance of a little bit of systemic absorption, which is very uncommon to actually get adrenal suppression from this, but it has been reported. But they really would have to be abusing that topical steroid. The most common thing we'll encounter is a secondary fungal infection, because you're changing the environment as a result of those topical steroids. COVID tongue, right? I felt like I had to bring this up. This was published and in the news, and so people know a lot of things about it. But this is not COVID tongue, okay? There's no direct correlation, as far as I'm aware of yet, to geographic tongue being associated with COVID infection. Most likely these patients had this prior to, and they just started noticing that, hey, my tongue looks different all of a sudden. But a lot of times patients aren't aware that they have geographic tongue, even in exuberant examples, just because they don't pay attention to their tongue that frequently. Excuse me. So recurrent aphthous stomatitis, this is one of the more common things that you are going to see. And I'm not going to go into too much detail with this because we covered this in my last lecture with a focus on underlying systemic diseases. But this is the classic canker sore. Okay, it's one of the most common oral pathoses that you will see affecting the mucosa. It's typically the result of a dysregulated immune response to some sort of antigenic stimulus that causes a destruction of those epithelial cells and an ulceration. Many things have been implicated, and the big thing to remember is it's probably different things for different folks, right? So there's SLS in toothpastes and other products, non-steroidal anti-inflammatory drugs, certain bacteria and viruses, foods, flavoring agents, preservatives, lots of different potential antigens that you could look at. Most often this happens in young kids. There are some underlying genetic susceptibilities. I've managed a handful of patients where their parents, one or two or both, have had a history of aphthous stomatitis when they were younger. 3 clinical forms that we see this in: minor, major, and herpetiform. Ulcers are recognized by variably thickened fibrin, that yellow membrane that makes us know that it's an ulcer with surrounding redness, okay? So the minor aphthous ulcerations is the most common one that you'll see. It accounts for about 80% of recurrent aphthous stomatitis. And you'll see these ulcerations that at largest are maybe a centimeter in size. They show really few recurrences and typically heal within 7 to 10 days without scarring, okay? So there can be anywhere from 1 to more than 5 ulcerations at a time. Patients will also sometimes complain of some altered sensation, burning, itching, or stinging prior to the breakdown of the epithelium as that inflammation really mounts a response there. Labial and buccal mucosa are the most common sites, and it rarely affects the keratinized tissue. So the difference between aphthous ulcers or canker sores and cold sores like herpes labialis or recurrent herpes in the oral cavity. So let's forget herpes labialis, but recurrent herpetic infection in the oral cavity has a tendency in immunocompetent patients to occur on bound down mucosa, whereas canker sores and aphthous stomatitis typically affects movable mucosa. Okay, so those are the differences that can kind of help you clinically distinguish one from the other. So a classic example of minor aphthous ulceration. Here's another one here in the lower lip. And here's one in the commissure area here, floor of the mouth. Recurrent aphthous, the major category, 1 to 3 centimeter ulcerations, and it can take anywhere 2 to 6 weeks to heal, 2 to 6 weeks to actually heal up. And these can actually cause scarring or result in scarring. And the scarring in some cases can be significant. These will affect the labial mucosa, the soft palate, as well as the tonsillar tissues in some cases. Larger ulceration, and sometimes it produces more of a nodulo-ulcerative sort of process, as there is a lot of inflammation and granulation tissue in that area. Here's one affecting the commissure, and you can see it's kind of affecting the entire aspect here of that lip. And here's a larger one affecting the tonsillar fossa here, in a large area of ulceration. And these can be a little bit more damaging and devastating to these patients, particularly when they're recurrent in nature, because they can really lead to significant scarring. Herpetiform is the one that's less likely. We don't often see these, but they're herpetiform because they kind of look like herpetic ulcerations, small punctate ulcerations, and sometimes a patient can have as many as 100 ulcers during an outbreak or a flare. Some studies do show a slight female predominance and an older age at onset, and any mucosal site is typically affected, and it typically does. This is one that typically affects the non-keratinized mucosa, but can also affect, on occasion, some of the keratinized tissue and bound down mucosa. So this is one in the soft palate. Again, movable mucosa kind of helps us separate these in most cases, where you get multiple little ulcers affecting the soft palate region. Here in the labial mucosa, again, not bound down to hard bone or hard tissue here, and multiple little ulcers or punctate ulcers in the labial mucosa. So things we do have to consider when we have recurrent aphthous stomatitis, underlying systemic diseases. And again, I'm not going to go into detail with this because we kind of discussed this last time. So when we treat patients like this, the first thing is to attempt to rule out a cause. Look at underlying systemic diseases, look at specific allergens that they may be reacting to, and see if you can determine something. I usually do a food diary for some of these patients, evaluate their products that they're using. Again, SLS is one of those things, so think about toothpaste, mouthwashes, things like that. And then variable methods are aimed at actually alleviating the symptoms based on the severity. So if you can't determine a cause, then we need to address your symptoms. And so you can use topical or systemic steroids, and those patients who have really severe disease can actually go on more aggressive immunomodulatory medications. Allergic reactions is a heterogeneous group of variable types of hypersensitivity. Systemic drugs, dental materials and metals, flavoring agents and preservatives. You can have all different types of allergic reactions. There's 2 basic types. Reactions that you are expecting, like warfarin and increased bleeding, or idiosyncratic reactions. So drug reactions that can be mimicking other inflammatory conditions like lichen planus, pemphigoid, pemphigus, lupus, or recurrent aphthous stomatitis. Okay. So this is a classic one. The patient had just started a type of insulin as well as an oral hypoglycemic. And this was biopsy. The patient had bilateral lesions, one on the left, one on the right. And this looked like lichen planus clinically, or I mean, histologically. And when we talked to the clinician, he said, well, this is the medication that the patient just started. We got the patient switched off of one of the medications, the lesions resolved. That's the classic situation where if you can determine the cause, remove the cause, you don't have to treat the patient for their symptoms, which is what you would be doing otherwise. So this is a great example of something like that. This is a patient who's on methotrexate, which is known to cause ulcerations. So we have some large ulcerations. And so we got in touch with the patient's rheumatologist, got them to get the patient off of methotrexate, or the clinician did. And then as a result, fairly quickly within weeks, we're starting to see complete resolution without active treatment of these lesions. Amalgam. these silver fillings and components of those silver fillings, especially with corrosion, can cause allergic reactions to some people. And so this is one that correlates to this buccal amalgam restoration. And once we've removed that and replaced it with a composite, we started to see resolution. Started to see resolution fairly quickly. You can see mucosal reactions to flavoring agents, particularly the biggest offender is cinnamon or synthetic cinnamon. And the concentration is almost 100-fold compared to natural cinnamon. And so oftentimes this can produce an exuberant immune reaction. One thing to look for is if you have a unilateral process affecting the lateral tongue as well as the buccal mucosa on one side. I talk to patients about dominance in chewing, and if patients chewing gum on one side, they may use it just on the right. When they chew that gum, all the preservative or the preservative or the flavoring agent that they're reacting to kind of hits that buccal mucosa, dissolves in their saliva, rubs up against the lateral border of the tongue. So the most exuberant place they'll have a reaction is on that one side. So that sometimes is a clue clinically that it could be something that they're chewing on, asking them how or if they favor a side when they chew. So this is one here. The lateral tongue is affected, and the patient's left buccal mucosa also shows that similar appearance to the lateral tongue. And this was a result of chewing Big Red. All right. This was a patient who had a tendency to kind of hold mints on the right side of the mouth, and it's fairly red-white lesion with ulceration, pretty significant, and not the best photo, but the clinician also biopsied the tongue on that side, and the histologic features were characteristic for a contact allergy. And so this was biopsied and it had suggestion of a contact allergy. And we asked the patient, or the clinician asked the patient about mints. Patient stopped using the mint. We saw resolution. So again, if I can not treat you for symptoms, which is not curing the disease process, again, the cure for this is determining the cause. So if I'm just treating you for symptoms, I'd rather not put you on medication. I'm a very conservative clinician. I like looking for the cause more so than actively treating the patients. Now, there's always going to be patients that are in severe pain that I do manage. I tell them that, hey, we can manage your symptoms for the time being, but we really need to dig into what could be causing this. So always be thinking about underlying factors, local stimulating factors, certain antigens that could be causing these sort of reactions. And I'm going to skip over the histology, but this is Lycan Planus on the left side, which is a disease process. We don't know what exactly causes it. And this on the right side is actually this patient here, their biopsy. Histologically, it looks absolutely identical. And I kind of matched this up on purpose. So as a pathologist, sometimes we can't tell whether there's any evidence of allergy or not. In this case, even though the superficial aspect looked like Lycan Planus, there was also some deeper inflammation, which was the clue that this was a contact reaction. But there are cases where we don't have any sort of distinguishing criteria on histology alone. And that's why it's really important for the clinician to be aware of these things. This is one as a result of toothpaste, and it's what we call plasma cell gingivitis, and it's an allergic reaction to some of the flavoring agents in the toothpaste in this situation. All right, disquamative gingivitis, again, continuing on with the chronic inflammatory disease process of the oral mucosa. Lichen planus, mucous membrane pemphigoid, and Pemphigus vulgaris are the ones that we're commonly going to see. And I'm not really going to focus on allergy. We've already kind of talked about it at this point. So lichen planus is an immune-mediated process caused by destruction of keratinocytes, or those epithelial cells in the basal cell region. We don't know what really causes it, and it can affect the mucosa and the skin. So this is a mucocutaneous condition. Typically, it affects middle-aged females, and it looks like a few different patterns, but the classic one is that reticular Wickham striate pattern that has the spider web-like appearance in the buccal mucosa bilaterally, as well as other sites. On occasion, it can be more atrophic and erosive or ulcerative in nature. And then very rarely do we get papular or bullous type lesions. And the bullous type lesions, there's some question whether that really represents lichen planus or not. Where do we see this? Buccal mucosa by far is the most common location, followed by the gingiva, the tongue, the palate, and the lips. classic Wickham striae or reticular pattern, which looks like little spider webs in the buccal mucosa. And in some patients, when it's just this white pattern, they're not symptomatic, okay? A lot of times when we start to see the erythema, the erosive pattern as well, that's when the patients do develop symptoms. Classically on the tongue, it causes this atrophic white-red appearance. And on occasion, you can actually have ulcerations with some of these lesions as well. So this is a patient who has the characteristic lesions on the buccal mucosa. It looks like it's affecting the lips and the tongue. And the patient has these lesions on his hand as well. And the classic lesions we associate with Lycan Planus on the cutaneous aspect are these purple pruritic polygonal papules, okay? And that's what we were all taught in dental school. And this was probably the best example I've seen, even though it's not the best photo, of these purple pruritic polygonal papules on the skin in a patient with Lycan Planus. And I'm not going to focus too much on this. We're going to skip through this a little bit here. Other disease processes that are known to produce a lichenoid reaction. I'm going to try to speed up a little bit. I realize we're running a little late. There's a handful of things histologically that can mimic Lycan Planus: graft versus host disease, systemic lupus erythematosus, chronic ulcerative stomatitis, which is another autoimmune disease, or actually an autoimmune disease as opposed to Lycan Planus, drug reactions, allergic reactions to amalgam and other topical substances and products. And the last thing being really important is dysplasia and early premalignant change. So precancerous lesions can also produce an inflammatory response from the body that will mimic Lycan Planus histologically. And so really important to have clinical correlation whenever you're submitting tissue to a pathologist for biopsy. And that's why there's this proposed checklist from a couple of years ago, big publication in one of our oral surgery, oral pathology, oral radiology journals. And they talk about the things you need to look for clinically and the presentation that can help the pathologist in making sure that the patient is getting the adequate diagnosis. So Lycan Planus is typically treated with class 1 or class 2 topical steroids. I often use clobetasol or Lidex, 0.05% gel formulation, or dexamethasone elixir at 0.5 milligrams for 5 ml. And then oral hygiene is key. Making sure that we reduce the background inflammation in any patient who has an oral inflammatory condition is very important. Sometimes patients do not respond to some of these local therapies, so you can actually use systemic medications, and that can depend on the severity of the patient's disease. Pemphigus is a vesiculobullous disease process, oftentimes seen in females that are middle-aged as well. And this is the one that really produces blistering. You'll see these irregular erosions in areas of desquamation of the tissue. All the mucosal tissues can be affected. Nearly 50% of patients will have oral lesions prior to skin involvement, and skin involvement is inevitable with these patients, okay? Oftentimes it looks like the skin is just kind of falling apart. It looks like you've just pulled the gingival tissues away, and you can imagine this is extremely painful. Being very careful during your exam, not just sticking your mirror in the cheek, because a lot of times that'll stick to the tissue, and when you pull that mirror back out, you will literally take all of the epithelium with it. So being very careful during your clinical exams is an important thing here. And you can see here multiple areas of erosion and ulceration, and this patient also has skin involvement. Inevitably, dermatology has to get involved, and they're usually involved from the very beginning. So this diagnosis is not something that you can just manage alone, because they will progress to have skin involvement in most of their cases. All right. Treatment, again, inevitably, you coordinate treatment with a physician, likely a dermatologist, systemic corticosteroids. For recalcitrant cases, people are using rituximab, and in some cases where they have severe disease, they are using rituximab and other more heavy chemotherapeutic agents for, or immunosuppressive agents for these individuals. And again, proper oral hygiene for any inflammatory condition is really key. So what is mucous membrane pemphigoid? It's different from pemphigus. It actually affects the cells that connect the epithelium to the underlying connective tissue, typically seen in middle-aged females. Again, middle-aged females do have a higher predilection for autoimmune diseases. When we see them in males, interestingly, we see them in younger males, not older females. And there's a couple of thoughts that kind of are complex in regards to why females are a higher predilection for developing these lesions, or these disease processes, I should say. What does it look like? Very similar to pemphigus clinically, but more often than not, you'll have gingival involvement. That's typically the most common site, and it looks kind of like this. And you can almost on rare occasion see some bullae like this or some blisters that are still intact. The oral cavity is such a friction based area where you have a lot of tissue rubbing, a lot of food in your mouth, a lot of talking, and a lot of trauma. So it's very rare that we actually get to see an intact blister in the oral cavity. But we can produce what's called a positive Nikolsky sign, which you can elicit a blister in an area that looks non-lesional. And so this is an example where this gentleman is just pushing the tissue away. Literally, you can peel that epithelium off because there's complete destruction of that attachment of the epithelium with the underlying connective tissue. And I really quickly have this, I think I'm gonna skip that and the histology as well. Really important with mucous membrane pemphigoid that these patients actually see an ophthalmologist. Some of these individuals will develop ocular involvement. This was a gentleman referred to me for the treatment or management of his oral disease. He had been misdiagnosed for years as having Lycan Planus when it really was mucous membrane pemphigoid. And eventually he ended up having conjunctival involvement, and it can actually cause adhesions to the globe and then result in what we call entropion, where the eyelids can turn inward and lead to blindness eventually. So this is one of those things that really is important if you have a patient diagnosed with this disease, that they follow up with an ophthalmologist at least once a year. All right, so I think we can go through this. Beth, am I running way too far behind?
Not too. Is this your last section?
Yeah, this and pigmented lesions are a short section.
Okay,
Yeah.
go ahead.
No, okay. All right. Sorry about this, everybody. I should have condensed this a little more. Causes of white changes. So there's a few different things that can actually result in white changes of the oral mucosa and gingival tissues. Friction is the most common cause that we'll see. You can actually see this sort of change as a result of some sort of chemical injury. Desquamation of the tissue or tissue necrosis results in that tissue becoming white. Clearly, leukoplakia or preneoplastic diseases can be white in their coloration, and we're not going to talk about those since we've discussed those previously. And then allergic reactions also can produce white changes that mimic some of the inflammatory conditions that we've also talked about. So Linea Alba is one of the most common things you'll see in practice. Most of us are pretty much aware of this. It's this little white band that runs along the occlusal plane, typically as a result of constant irritation from the teeth, or some sort of little suction habit that takes place, and it's not necessarily parafunctional, but it's just enough to cause this white change that is really something that is insignificant. No need to actively treat or biopsy these patients. Frictional keratosis, this is sometimes a little bit more scary in its appearance. It's a result of masticatory trauma in most cases. Alveolar ridge keratosis, we can see this in the edentulous areas. Retromolar mucosa and pad is a very common location to find this, but you can also find this under ill-fitting dentures or just in edentulous bands as a result of food impaction and constant trauma. And the epithelium really tries to toughen up. And so you get this thickened epithelium that produces a little more keratin on top that clinically looks white in appearance. Classic example of frictional keratosis here in the buccal mucosa. The patient had a parafunctional habit of just kind of chewing on their cheek when they were anxious and produced this on their cheek here. And another patient who also had some frictional keratosis on the tongue. And again, we can see this most often in the cheek, but we can also see it on the tongue on occasion. Anytime you see a white lesion, always try to determine a cause, right? So we look for, is this pseudomembranous candidiasis? Is it wipeable? No, it's not. Well, is there something sharp that could be rubbing against this? And in this case, there was a little tine that had been since removed here on this gold crown that correlated with this area. There's a little bit of an ulcer here. And so this was smoothed off here, and we asked the patient to come back in 2 to 3 weeks. And lo and behold, we've gotten rid of this lesion. So another great example of chronic irritation from friction. And so looking for sharp cusps, looking for, irregular margins on restorations, anything that could be causing a little bit of friction is really helpful. A really good example of alveolar ridge keratosis in a patient who has an ill-fitting denture that is also causing that chronic irritation or trauma. All right, chemical injury. Could be any number of things that can actually cause this sort of chemical cautery to the tissue. It could be from aspirin. It could be from hydrogen peroxide, silver nitrate phenols. Oragel is known to cause chemical injury as well. So patients who have a really bad toothache who are overusing Oragel could also have this sort of process develop. And there's a lot of other products that can actually be a little bit caustic to the tissues. This is a classic example of a chemical burn as a result of a patient putting an aspirin from a toothache. And so this is one of those that, again, is causing desquamation and chemical necrosis of that tissue. And so it'll just come away, and this is going to be painful. This is an Excedrin burn in this patient. Patient had a toothache back here, and this looks very much scary whenever you see this. And you ask the patient, and the patient had constantly been placing Excedrin in this area, which has aspirin in it, and it was causing a necrosis of that tissue around it. And again, it's that chemical that really is causing, that is caustic and causing necrosis of that epithelium and resulting in damage. Oftentimes we'll see this, just the superficial slough that sometimes piles up in people's mouths. It's thought to be whether there's some question whether it's really allergic or chemical. I've had patients that it's a result of the mouthwash, and I think it's more likely from the caustic nature of the mouthwash as opposed to an allergic reaction. There have been cases of this that have been biopsied, don't really show an exuberant immune reaction to it. And so it's likely that it's just causing enough significant damage of that top layer of epithelium that it just kind of sloughs away. So again, looking at their products, looking at other things that they may be using goes a long way for cases like this. All right, last category here, pigmented lesions. First thing you think about is, why is a pigmented lesion pigmented? So you're looking for extrinsic factors, any sort of superficial stain, which with enough pressure could wipe off on your gauze, or whether it's something implanted. Is this something really in the tissue? It's not going to wipe off, and if it's not blood related, from increased vasculature or increased blood within a large vessel, it's not going to blanch, right? So when you put pressure on it, it's not going to turn white. Blood pigments can also cause this, but we're not going to really go into these lesions, the intra and extravascular. These will typically blanch under pressure if they're intravascular. So hemangiomas or varices will blanch. If it's hemorrhage into the tissue, it's going to be in the tissue. Those are lesions that may not blanch. And so being aware of petechiae, purpura, and ecchymoses, or a bruise that can also affect the oral mucosa, is another thing that can cause a pigmented lesion. And then the last thing, melanin pigmentation, which is not going to wipe off or blanch either. So localized, we kind of break this down into whether it's going to be something localized or generalized, and a few different thought processes about what goes into that as well. So the first thing is a hairy or coated tongue, and the coated tongue is really what we're here for, the pigmented sort of coat on people's tongue. So the first thing you try to do is determine a cause. Is there something in their diet that is causing this? Are they not having proper hygiene? Are they not cleaning their tongue the way they're supposed to, right? Hairy tongue oftentimes is a result of multiple factors. Some people think that it may be poor oral hygiene or patients who have xerostomia, but we don't know exactly what results in a hairy tongue in all these individuals. More often than not, mechanical debridement and proper oral hygiene of the tongue is going to make a difference. And oftentimes you can actually see a difference in the staining or the coated tongue in these patients as well. Sometimes patients can present with a black coat on their tongue, and then that's when I ask them if that's something, have they taken a Pepto-Bismol? Have they taken any sort of other bismuth containing compound because they've had some GI distress? And that could correlate to that black appearance, which can also discolor the stool in some of these patients. So really great example of hairy tongue, really, and this is very pigmented from tobacco products that the patient was using, but really prominent filiform papilla. The patient just never cleaned their tongue. So getting them into a proper hygiene habit is going to be huge for cases like this. A really coated tongue from the teas that this patient was drinking, that would have a tendency to kind of colonize that thick coat on top of their tongue and result in this sort of extrinsic pigmentation. Here's an example of a bismuth coated tongue and really black in appearance. Nothing to be worried about. Again, asking them about their products, asking them about their diet goes a long way. So implanted pigmentation or implanted extrinsic pigments can be a result of amalgam or silver fillings that we place, graphite tattoos, and some of them can be something that the patient is doing themselves, like a decorative tattoo. Amalgam tattoos are typically slate gray or bluish in color, and it's typically the result of silver deposition among the collagen fibrils in the connective tissue. It can be at the site of an amalgam or a previous amalgam, or it can be in a distant site, a distal site, away from that amalgam because there was a breakage in the tissue that allowed for seepage of that silver salt into that wound, or it's implanted into that area. So this is kind of the classic appearance of an amalgam tattoo. And if you're lucky enough, if the particles are big enough, on occasion, you can illustrate the particles on a radiograph. And that's fairly diagnostic that that's what this is. But more often than not, these are diagnosed or biopsied and then made. The biopsy results are typically the way these patients are diagnosed and monitored from there going forward. This is one where the patient has no history of amalgam restorations, but they did have a retrofill from surgical endodontic procedure years ago. And this was back when we used to use amalgam for retrofillings. And this was a patient who had amalgam tattoo as a result of that retrofilling from the endodontic procedures. Graphite gets implanted into the oral cavity, funny enough, more often than we think. People put a pencil in their mouth, and if they have some sort of accident, it gets embedded into the tissue. Sometimes people forget that they actually ever had that accident. And so it can have this sort of appearance as well. And then decorative tattoos, everybody should be familiar with in regards to people that get their tattoos. There is a specific type of tattoo we've seen on the gingiva here at the college, as well as fairly reported across the world. In certain populations, sub-Saharan Africa, South America, and other countries, people will get these aesthetic tattoos or tattoos that are thought to be for medicinal purposes as part of their culture. And they'll get this banded tattoo on their gingiva, whether it's maxillary or mandibular or both. This is a patient who had this lesion. And anytime we see a pigmented lesion, there's a few different things that come into our differential diagnosis. And so the clinician was worried about it. They thought, man, could this be something like melanoma? It's not normal in its architecture. It's not symmetrical. The color kind of varies. And so he biopsied this, and histologically, it looked like graphite. Then they asked the patient, did you ever have a pencil injury or something like that in your mouth? Patient recalled, oh my gosh, when I was a child, I was running with a pencil in my mouth and it kind of jammed up into the gums. So this is a patient that was from Senegal that we had seen at the College of Dentistry that had this sort of cultural tattoo across their gingiva here. And again, you can have patients that will present with these sort of decorative tattoos. I like to think that maybe WHOA, instead of just standing for woe with a period, stands for Wooden Stick Horses of America. I think that's a little bit better than just woe. And then the last category are melanocytic lesions or melanotic lesions. You got to be aware of physiologic pigmentation. Sometimes patients aren't aware of this until they're made aware of this. So if a patient says that all of a sudden I have these, this sort of discoloration in my gingiva, be aware of physiologic pigmentation in specific populations. Typically, it's not going to affect the marginal gingiva. It can be on occasion found on the buccal mucosa and tongue. And again, like I said, it's typically been there for a long period of time. Patients may not have noticed it. So again, it kind of spares that marginal gingiva, has more of a generalized distribution. It's not splotchy, almost a homogeneous color. And this is a classic example of physiologic pigmentation. A melanotic macule is the oral counterpart to a freckle on the skin. Typically, it is a flat brown-black lesion. It gets as large as maybe 6 to 7 millimeters. It doesn't grow. It's stable after that. We don't know what really causes it. It's not like a freckle on the skin and its association with UV radiation. It really is an unknown etiology. Commonly found on the lip, but the lip, there's some indication that it's likely from sun exposure. So this is a good example of an oral melanotic macule. And again, biopsy and excision is going to be curative for something like this because there are, in some cases, questions whether this represents a benign pigmented lesion, or on occasion where we start to see some discoloration or anything else, we may consider something a little bit more worrisome. So this is a little bit larger lesion on the palate, and it shows a little bit of variable pigmentation. So we start to think about our criteria when we're evaluating for melanoma, the ABCDE criteria, which I'll go over in the next couple of slides. And so this was a little bit clinically worrisome. It was biopsied, and it was a melanotic macule. This is when we start to get concerned, when we see something like this, a large lesion bigger than 6 millimeters, asymmetrical borders, variation in color. This is kind of checking off all the boxes of being worrisome for melanoma. And oral mucosal melanoma is one of those disease processes that has a roughly 15% overall survival rate. And so it's really something that can be concerning. In this case, this is what we call an oral melanoacanthoma. And this is a reactive lesion that you guys should be fairly familiar with, often seen, most often, in young, middle-aged African-American females as a result of some local irritation that produces this sort of worrisome pigmented lesion, okay? But oftentimes it is biopsied because it mimics melanoma to a degree. And on biopsy, the histologic features make us consider melanoacanthoma this reactive process. And then you have to find that irritating factor and remove it. And as long as the lesion resolves, this is what it is. If it is persistent, then we need to reconsider our thoughts on what we were seeing at the histologic level as well as what we're seeing clinically, and it may be time to rebiopsy that patient. All right. This is why all this is important. A third of oral mucosal melanomas have a prior clinical, not biopsy-based diagnosis, clinical diagnosis of a benign pigmented lesion, such as a melanotic macule, amalgam tattoo, or something else. All right. So a third of these lesions are just clinically written off as something else. And that's why it's really important to be aware of pigmented lesions in general. That's why we use our ABCDE criteria: asymmetry, border irregularity, color variation, a diameter greater than 6 millimeters, and evolution, any evidence of change or further growth or development of other lesions in the area, right? This is an example of oral mucosal melanoma. Kind of looks like physiologic pigmentation here, really dark, involves the marginal gingiva, and it's only localized to this quadrant and involves the palate here as well. And this is a classic example of oral mucosal melanoma. My goodness, we did it. I am way over time and I apologize for that. Thank you so much for sticking around. Beth, I am sorry. I appreciate the opportunity as always. It's been so much fun to do these seminars for you guys. So thank you.
And we thank you, Dr. Patel. This was such great information and your slides are wonderful. We will change our evaluations. If everyone will give us about 5 minutes to change that, we want to increase the time for the continuing dental education to 1.75. So you get an hour and 3/4 credit today. Now, I would like to open up, let's see if there's any questions in the chat box, but also if you will select the raise hand feature at the very bottom, we can unmute you and you can ask your questions verbally to Dr. Patel. I see a lot of thank yous and good information. So we're looking for any questions. Did anybody have anything they want to ask him while he's with us? Well, again, we will be putting the recording on our website the first of next week. And also, we are working with him to develop these into self-instructional courses where you can take the whole thing and get full credit and just do it online. Let's see. Oh, here is a question. How do we encourage our doctor to go forward with biopsy? I think you're muted, Dr. Patel.
So is this coming from a patient standpoint, or is this from part of the oral healthcare team encouraging the doctor?
She's an RDH. Just
okay. No, very good. So it depends on the situation. If you know, and I teach the oral path hygiene course here at the college, and I'm just a huge fan of hygiene in general because I had some great experience with public health and hygiene, the hygienists that I had. But hygienists particularly, you're going to be more likely to see patients more frequently than the dentist in many cases. And so it's one of those cases that it really is going to be dependent on the lesion. It depends on what we're dealing with. I mean, we went over a lot of stuff today, But if there's any change in a lesion, if there's any sort of worrisome clinical features, and again, this can be so variable case by case. If we're talking about pigmented lesions, photo documentation every time you come in. If there's any sort of, if we assume it's an amalgam tattoo, clearly it can help if you have some sort of evidence that, hey, they had an amalgam filling here. If clearly there's no indication that they ever had a silver filling, then I think that's something that we need to biopsy. Some dentists may want to watch a white lesion, and that's understandable in some cases. I'm a huge proponent for, if it's a white lesion that we don't know what's causing it, it's a leukoplakia clinically, and we need to biopsy that. So it's one of those cases where it can be a little bit of a tough conversation. But if there's something specific that you want to ask about, I mean, I'm more than open to kind of discuss that with you. And again, I guess it's a little bit broad, I guess, for me to say that, whether we watch or not, it kind of, whether it's pigmented lesions, a bump, or white lesions, it could change. And it really kind of becomes case by case. If the dentist wants to watch, you can always at least try to say that, this looks like it's changed, or whatever's happened over the course of time through your photo documentation. And if there's something like that, you can always recommend that, hey, maybe we can get a second opinion. That can probably become a little bit contentious depending on how the relationship is with you and the dentist. But if it's something that needs to be biopsied, we're looking out for the patients. That's number one. So if you think it needs to be biopsied, you definitely need to at least voice your opinion, or at least say that, hey, maybe we can get a second opinion on this. I don't know if that helps.
Well, that's a good suggestion. I know firsthand doctors like to say, let's watch it for 2 weeks.
Yes.
Come back in and do a tissue check it again, see if there's been any change. And then it's always good also to try to develop some relationship with an oral surgeon, local oral surgeon.
Yes.
Yeah. That you can get that second opinion. You can say, well, how about we send them to so-and-so?
Yeah.
There is a question in the Q&A. If you have any preferred textbook or app that you recommend for use as a reference or a go-to.
Yeah, no, I think that's a fantastic one. There's actually an oral maxillofacial pathology atlas by Carl Allen. Let me see. And what this atlas is it literally is pictures and then a short little blurb about the disease process. And so I'm a huge fan of that kind of visual learning, and it helps you kind of correlate with what you're seeing as well. Anyways, it's about getting the text. And if there's ever, I've made my information available. Beth, I know you and Jessica both have it, but if there's ever anything that we can do, we're here for the state. And so we're a resource. If you ever have questions, I can't tell you how many times a week I get something from the region or somewhere across the state, whether it be people that have gotten in touch with me through lectures, or people that I've done residency with, or colleagues, or they've heard about me from one way or another, that will get, hey, what do you think this is? And I'd be more than happy to do an informal consultation with you, given that that you guys are open to it. So that's all of us here. Yeah,
that's great.
Yeah.
And I know that we've even referred patients to the stomatology clinic there in Dallas. Yeah. And when we can't find what the answer is, it's like, let's send them to the experts.
Yeah.
So thank you again to all the attendees for joining us today. And thank you, Dr. Patel, for these wonderful webinars that you've done for us. We really appreciate it.
Thank you guys so much. And again, I apologize for running late today, guys. It was a little bit more than I expected, but thank you for being patient with me.
Well, it was worth it. Thank you again, and have a great weekend, okay?
Yep, you too.
All right.
Bye.
Thank you. Bye-bye.